Thank you, sir. Thanks for the introduction. Today I'm going to talk about this common disorder, polycystic ovarian disease. Since I am a gynecologist and I deal with females, so we see a lot of young girls and even married couples who are struggling with infertility, and young girls who are struggling with irregular menstruations and delayed menarche, obesity, hyperandrogenism, hirsutism. So this is what this disorder is, polycystic ovary. So we are treating polycystic ovary because people are sensitized to it. Patients do come with this problem. It's a common problem. And today I want to talk about the uterus, what effects polycystic ovary has on the uterus in the short term and in the long term, which cannot be forgotten. Because the people with PCOD, they need lifelong care and they need follow-up regular. Even after they've completed their families, they've had children, they still need to see their gynae to prevent the other problems which are associated with it. So it is a multifactorial disorder which is affecting 8 to 13% of all women of reproductive age. And this was first described in 1935. So we don't have a clear etiology to this problem. We don't know why it happens. But like diabetes, it is a multifactorial problem, and genetics do play a role, and environment and lifestyle also plays a very big role in this disorder. The diagnostic criteria are also controversial, but since like so many years we've been studying, there are two important things. 2 out of these 3 criteria should be present in a female if we want to label her as polycystic ovary. The first and foremost is oligo-anovulation or anovulation, because the infrequent oligo-ovulation means usually a girl would, after menarche, after the start of menses, she would menstruate every 28 to 30 days regularly. So in patients who have polycystic ovaries, the ovulation will not happen regularly. So she will miss her periods. She will not menstruate every month. She may not menstruate without medicine. And she would also show some biochemical changes like hormonal changes. Her LH, luteinizing hormone, which is coming from the pituitary, is raised compared to the FSH. Then she has signs of excessive androgen in the body, like excessive hair growth, facial hair, and hair on the upper body, upper back, so which is called hirsutism. So these 2 are the main criteria: irregular menstruation, infrequent menstruation, which is because of irregular ovulation, and second, hirsutism. So the third criteria, which is the picture morphology of the ovary, the picture on ultrasound, polycystic ovary, this is not an essential criteria, because in young adolescents, even a normal ovary could give that picture of a polycystic ovary. In young girls, there are a lot of follicles in the ovary, and sometimes they are mislabeled as PCOD. So when somebody has started menarche and she has irregular period, so we should watch such girls for 2 years. If she persists to have irregular cycles even after 2 years of beginning of menstruation, then we should think about polycystic ovary, not the first 6 months or the first 5 months, because the menarche can also mimic PCOS. The first 2 years after menarche, girls can have irregular periods, and that is because of the immaturity of the HPO axis, and not every time because of polycystic ovaries. Now here is a little picture. On my left, we have the ultrasound picture. So this is how it appears on ultrasound. You can see that the ovary is bigger in size, and the outer surface is very smooth. Normally, it is not so smooth. And then you have a peripherally arranged multiple small follicles. These are basically atretic follicles. And then if you look at the stroma of the ovary, the stroma is very thick. This stroma of the ovary is very thick. In a normal ovary, you see follicles all over. They are spread throughout, and the number is like 8 to 10. But in a polycystic ovary, the number could be anything between 20 to 30 to 50, depending on the severity of polycystic ovary. And if you see the laparoscopy picture, this is the uterus. Uterus is normal in size, and here you can see that the ovary is almost as big as the uterus. In a normal patient, the ovary would be like this, 1/3 of the size of the uterus. So the severity of PCOS will depend on the size of the ovaries and the number of follicles also, and the thickness of this stroma. So this is how it is diagnosed. So ultrasound is a very good tool to diagnose. We don't need to do a laparoscopy in a patient with PCOD. just an ultrasound, and then clinical picture, then history, and hirsutism assessment, then hormonal test. So this is what is important to label somebody as a polycystic ovary. So now, what is the impact on the uterus? In a PCOS, it can have several changes on the uterus. First, menstrual cycle dysfunction. This is a diagnostic criteria even for PCOS. But PCOS can also lead to change in the morphology of the uterus. So certain studies have been done on rats, and they have been exposed to increased androgens, and it has been seen that it leads to certain changes in the uterus, like decrease in the length of the uterus or increase in the muscle of the uterus. And those things can later on present like preterm labor, premature birth, and all those things. Though it has not been proven conclusively that it changes the morphology, but there are studies going on, and will have more knowledge, will be more knowledgeable in the years to come. Then PCOS also affects the pregnancy. It affects the implantation and the uterine receptivity. So this we commonly see in patients who have PCOS, even after treatments of fertility, the pregnancy rates are lower because of reduced implantation. And even if they get pregnant, there is increased risk of miscarriage in such patients because of impaired uterine receptivity. Receptivity depends on the inflammation, because it is a chronic inflammatory state also. And there is immunoregulation is disturbed in such patients. We are going to see that in detail. And then in the long term, in the long prolonged exposures to increased estrogens and androgens can lead to endometrial hyperplasia, so which is a matter of concern. So even after the childbirthing and all, everything is done, we need to monitor our ladies who have PCOS for endometrial hyperplasia. And for this, we need to do a simple ultrasound and measure the endometrial thickness at regular intervals, like at least once a year. And if she has menstrual disturbances or heavy bleeding, then it can be done whenever she has that problem. But at least once a year, that patient with PCOS should get an ultrasound done to see what her endometrial thickness is. So I've already touched this. So there is something about cervicofundal uterine peristalsis, which they say is decreased in women with PCOS, and this can also contribute towards infertility. Now, uterine dysfunction in pregnancy is mainly because of impaired endometrial receptivity, compromised decidualization when the pregnancy occurs, then hormonal dysregulation, then heightened inflammation and immune system dysregulation. So PCOS women, they may have increased risk of incoordinate uterine activity during pregnancy and labor and implantation failures and miscarriages also. So even during pregnancy, we need to monitor them. We need to see whether there is any cervical shortening, and this monitoring is also done with ultrasound. If we see that the cervix is getting shortened and the patient is going to have a preterm labor, then certain interventions can be done, like a cervical stitch can be put, or she can advise rest, bed rest, and all those things can be prescribed to this patient so that she takes the pregnancy to term and she delivers a good weight baby. So here, this is a very important, simple graphical representation of a normal menstrual cycle. So if we see a normal lady who is not a PCOS, we see the pituitary hormones. FSH is this red one, and then LH. So we see that in the mid-cycle, around the day 14, day 12, there is a peak, and then it falls down. And this LH peak leads to ovulation. And the rest of the days, you see that FSH and LH, they are both at a lower level. Whereas in PCOS, this LH, the yellow line, it is tonically raised throughout the cycle. So this LH is always raised for this patient. LH leads to more androgen formation in the body. And even the FSH, the peak of the FSH is not so prominent, and LH is the main dysfunction actually. This is coming, peaking and going down, but this tonic LH leads to anovulation. It leads to abnormal follicle formation, it leads to increased androgen synthesis, and it leads to all the problems which are associated with PCOS. if we look at our common hormones, estrogen and progesterone, so because of those FSH and LH changes, in a normal lady, so this green one is the androgen. This is the androgen which goes up and it falls down. And in the later half of the cycle, the progesterone will peak, which is represented by the purple line. So progesterone will peak in the second half of the cycle, after the day 14. In a PCOS patient, this progesterone is always low. Progesterone is one hormone which reduces cell proliferation, it reduces hyperplasia, it will reduce the cell activity, cell division. So this is the hormone which is controlling the thickness of the endometrium in the uterus. So in a PCOS, because the progesterone is always deficient, that check on the endometrial lining and thickness is not there. And on the contrary, the estrogen and androgens are raised. The green is androgens, which are raised in PCOS patients. So usually these patients have hirsutism. They have a lot of hair on the body, like male type distribution of hair on the body. So these are the two things which are very, very important. And the treatment also, we have to bring down the LH, we have to increase the progesterone. Some of these patients could be resistant to progesterone, so there we use metformin and oral contraceptive pills. So the treatment remains the same for all the disorders which are associated with PCOS, but the important thing is we cannot ignore these women once their family is complete. We have to educate them and keep them on follow-up. At least once a year, we should check for other problems which can come because of polycystic ovary. I've already explained all this. So basically, progesterone will increase in the second half of the cycle, and this doesn't happen in a polycystic ovary. And deficient progesterone, and there is a constant E2 estradiol which is present. In a normal female, we would see that estrogen is low, then it peaks and it becomes low again. In a PCOS, it is raised. LH, estrogen is raised throughout the cycle, which is leading to endometrial changes, and those changes if they persist for few years, they can lead to heavy menstrual bleeding and unpredictable bleeding patterns. So even insulin resistance, so PCOS and metabolic syndrome are very much associated. So it's not only the uterus and the ovary which is being affected, it's the whole body. It's like diabetes, where even the lipids are deranged. They are prone to diabetes, they have insulin resistance, they always have increased insulin and increased androgens. And this amplifies the stimulatory effects of estrogens, which leads to unopposed estrogen exposure in the endometrium and heavy menstrual bleeding and unpredictable bleeding patterns. So this is just a diagrammatic representation. We can see here, this is white line, this is the endometrium, this is the normal endometrium. But in a PCOS, you can see it has become thicker. This becomes thick, and sometimes the patient doesn't even know. She says कि मुझे तो periods पहले भी नहीं आते थे, अब भी नहीं आ रहे, और हमारे पास आती है वो. She comes with heavy bleeding. That bleeding has been going on since a month, and then we look at her on ultrasound. हम देखते हैं कितनी bleeding हो रही है, उसके बाद भी endometrium is 20 mm, very thick. So in such patients, we need to do an endometrial biopsy. Endometrial curettage करना होता है, and it has to be sent for histopathology to rule out whether she has any ertepia or cancer forming in the uterus. So that is very, very important in such patients. So first in ultrasound, if the thickness is low, normal, like 7 to 12 mm, it's okay, we can leave the patient. If the thickness is more than 15 mm, we definitely do an endometrial biopsy for such patients. So again, in adolescence, when a girl comes with irregular menstruation, so it's not good to label her as PCOS just on an ultrasound diagnosis, which is showing a big ovary and number of follicles are raised. There we have to wait for 1 to 2 years, because 50% of these adolescents would not have PCOS, and the problem will go after 2 years. So when symptoms extend beyond 2 years, the menstrual dysfunction could be considered as a marker of hyperandrogenism, PCOS, and metabolic disorders in later life. I think we've already discussed this. Increased androgens, increased androgen receptors, decreased progesterone, and this leads to endometrial dysfunction. Endometrial dysfunction in pregnancy, again, it is because of the type of estrogen receptor is also different in these patients. They have more of androgen receptor alpha, whereas in normal patients, we have more of androgen receptor beta. So in PCOS, higher ER alpha receptors in the mid-cycle versus ER beta receptors, they lead to decreased progesterone. And increased progesterone resistance is also seen in PCOS patients. Sometimes just progesterone is not going to treat her because they might be having different genetic expressions and increased estrogen resistance, which can lead to decreased implantations. So as in PCOS, especially in obese PCOS and in PCOS where hyperandrogenemia is there, metformin is a very good drug. It is a cheap and good drug which decreases the insulin resistance. It increases the implantation and endometrial receptivity in PCOS, and altered endometrial receptivity present through a number of possible mechanisms at the molecular level. So it is because of the insulin resistance and hyperinsulinemia, because of obesity, because of the pro-inflammatory cytokines, because of hyperandrogens, and because of progesterone resistance. So all these 6 problems, they can lead to pregnancy losses. And metformin has been found to improve decidulization in the stromal cells and improve the implantation also. So usually metformin is given in a dose of 1500 milligrams daily in our patients. And we don't start off with 1500. We usually start with, we gradually increase the dose because the side effects are there. So people may not tolerate 1500. We usually start with 500 to 750 and gradually increase and take it to 1500. So which is a very good drug. And it should be continued in these patients. Throughout life also we can give. Because insulin resistance is going to present later as diabetes and dyslipidemia and all those problems will come. So metformin, systemically, it is going to improve the insulin resistance and serum androgen levels. And intra-ovarian changes are also happening because of metformin. It will improve the ovarian environment by local effect on ovarian steroid genesis and intra-ovarian insulin resistance. So there are 2 organs which are making the androgens in PCOS. One is the ovary. Ovary, under the effect of extra LH, is making androgens. And the adipose tissue is also giving more androgens. So in obese PCOS, so the most important intervention is diet and exercise and weight loss. In those patients who are obese, because in PCOS we can have 2 types of, we can have different spectrum of phenotypes. We see a variety where the patient is very lean and thin and she has a polycystic ovary, she has hyperandrogenemia, she has hirsutism, irregular periods, but she's very lean and thin. So this patient is also a very difficult patient because she is prone to all the complications that are seen with PCOS. Even during pregnancy, during fertility treatment, this patient is at very high risk of ovarian hyperstimulation syndrome. So lean PCOS, and then the second variety is the obese PCOS. In an obese PCOS, the first and foremost is the diet, weight loss. Sometimes their menstrual irregularity can reverse just with weight loss and healthy diet and healthy lifestyle. Her symptoms can reverse. So even the intra-ovarian environment is affected with metformin. It improves the paracrine insulin relating signaling, it improves the receptivity, so it is beneficial at all levels. So endometrial hyperplasia. Now progesterone-based contraceptives, they are used. Normally when a patient comes with endometrial hyperplasia and we have done an endometrial biopsy, we have ruled cancer, we have done a curettage, but we need to give her something so that her endometrial thickness remains thin and she doesn't have abnormal uterine bleeding. So usually we give progesterones in such patients. Even intrauterine progesterones can be used, like we have devices, progesterone releasing devices, which we put in the uterus and that device gives progesterone for 5 years and the patient doesn't need to take it orally. Then we can give progesterone on a cyclical basis also. We can give it in the second half of the cycle, especially when the patient wants to conceive. We give it in the second half and that also gives protection to the endometrium. But in certain patients, their progesterone resistance could be present, where just progesterone may not help. There we need to have an alternative plan to prevent endometrial hyperplasia. So there we use metformin and oral contraceptive pills. Low dose oral contraceptive pills along with metformin is used in those patients who have progesterone resistance. This is an ultrasound image of the endometrium. So this is the endometrium. It is thick, and then you have this hypoanechoic areas in the endometrium. So this is a typical endometrial hyperplasia, where we call it a cystic hyperplasia of the endometrium. And this is a Swiss cheese appearance. So this is very typical of polycystic ovary. So association between polycystic ovary and endometrial cancer was described 60 years ago. And if we see at the risk of endometrial carcinoma, it is 3 times higher when we compare the PCOS to the non-polycystic ovary patient. And endometrial carcinoma risk becomes 4 times higher in PCOS women with endometrial hyperplasia. Even in endometrial hyperplasia, it can be of 3 types. It could be a simple hyperplasia. A simple hyperplasia is not that bad. There we give 6 months of progesterone and the signs are reversed, and we can give then cyclic or long-term progesterone. Such patients we usually don't do surgeries in simple hyperplasia. We don't do hysterectomies. We treat this with progesterone. But if the endometrial hyperplasia is associated with atypical cells, atypia, there we need to do something. And there we need to counsel the patient, follow her up. Sometimes even that can reverse with progesterone, but regular follow-up is important. If that changes to cancer, then definitely patient needs radical treatment for cancer. So this is the ultrasound picture of endometrial cancer. Here you can see that the endometrium is thick, plus you can see this is the hyperechoic and heteroechoic endometrium. So there, when we see something like this, we need to do again a biopsy and confirm the diagnosis, a hysteroscopy biopsy or a simple endometrial biopsy, endometrial curettage, a fractional curettage. So such patients would need a good thorough curettage, then a histopathology would be done, and then the patient would be treated for endometrial cancer. So our PCOS patients, they are high-risk patients, they have to be followed up for all these changes by ultrasounds. Metformin and cyclic OCPs have successfully reversed early stage endometrial carcinoma in women after 6 months of treatment. And metformin is known to have a synergistic anti-tumor effect to progesterones on the endometrial cells, even in vitro. It has been found to be helpful, synergistic anti-tumor activity. And mechanism of action is through increased progesterone receptor mRNA and protein expression in endometrial cell lines. And short-term pre-surgical treatment with metformin also decreases cellular proliferation, which is assessed by Ki-67 and proliferation index. And metformin induces apoptosis also, cell death and apoptosis in endometrial cells. So metformin is a good and cheap drug which is available to us for our patients with PCOS. Along with progesterone or oral contraceptives, it can be used in these patients. So we've already done this. Now, prevention, how can we prevent endometrial carcinoma? First and foremost, reduction of BMI in those patients who are obese. Then progesterone-based therapies, either systemic or local. Then 30% of women with PCOS do not respond to progesterone. So in these patients, we can combine metformin and OC pills, which is a good alternative. Metformin has a synergistic action to progesterone, and short-term metformin pre-surgery will also affect the cell proliferation. And in vivo and in vitro studies have shown value of metformin in reversing simple endometrial hyperplasia, but we need further studies. So the key points regarding polycystic ovary and uterus molecular pathways, there are alterations in the uterine molecular pathways, increased estradiol, enhanced ER alpha receptor activation, increased progesterone receptor expression, upregulation of androgen receptors, increase in expression of ER alpha and androgen receptors in the epithelial and stromal cells, higher PR expression, particularly in the epithelium, enhanced P160 steroid receptor co-activator. These are the molecular pathways which are responsible for giving us these changes. So to conclude, PCOS is a complex and multifactorial disorder which is affecting around 30% of the subfertile couples. So 18 to 13% in the general population, in the normal population, 30% in the subfertile population we see PCOS. Endometrial and uterine dysfunction plays a pivotal role. Women with PCOS present with menstrual dysfunction affecting the uterine health in the long term, leading to endometrial hyperplasia and cancer also later. And metabolic disorders associated with PCOS, they include hyperandrogenism, hyperinsulinemia, insulin resistance, dyslipidemia also, and diabetes also. Type 2 diabetes can come these patients at a younger age. Data regarding the effects of PCOS on uterine morphology and function, pregnancy, as well as initiation and induction of labor are sparse. And recent studies indicate that adverse endometrial changes could be reversible with anti-androgen and metformin. However, no specific treatment strategy can be recommended at this time, highlighting that more studies are urgently needed. And this underlines the need to address these issues in future studies. Thank you.